Thank you, Suvin. And this is, in fact, a great course that Suvin gives at the Academy and ASCRS, and always a pleasure to be a part of it. And you're going to hear so much about the devices, and Suvin's going to show you this very clever expansion ring. So I thought I would just again focus more on the pharmacology. And I think the first thing is, is Tamsulosin. I'm going to basically highlight two studies from the past year. If you look back, this is a nice meta-analysis of the literature, 17 studies, and it seemed to show that Tamsulosin was the number one most frequent cause of more severe IFIS. And so with that in mind, let's look at what this is historically. So for the longest time, these were the alpha blockers, terazosin, doxazosin, treatment for blood pressure and for BPH. And they work by blocking the alpha-1A receptor in the prostate. So, that relaxes the smooth muscle in the prostate. But they also block the smooth muscle in the vascular smooth muscle wall. So that can create postural hypotension. And so when Tamsulosin came along, later silodosin, it had the advantage of being specific for just the alpha-1A, and it was less likely to cause postural hypotension. And Suvin kindly looked up for me and determined that Tamsulosin here in India may often be Veltam or Uramax. So by being selective for the 1A receptor, what does that do? Well, it means that you're not going to block the smooth muscle receptors, making postural hypotension less likely. Now, Alfuzosin came along next, and in India, that's Alfuzosin. And this is also non-selective. It blocks the alpha-1B also. But because they managed to slow down the absorption from the GI, it doesn't create this spike of drug effect, so it really doesn't cause postural hypotension. So these two drugs are basically the safest from the cardiovascular standpoint. And so this study that was published in this last year, we decided to look at, of these two drugs that have the best safety profile, is one of them preferable, knowing that someday the patient would need a cataract operation. And this was actually a difficult trial to do because Tamsulosin in almost every country has the lion's share of the BPH market. Alfuzosin is made by Sanofi Aventis, so they do have a decent share in France. And for that reason, we did our multi-center trial in France. It took me about 2 years to figure out how to do this trial. It was a prospective trial where every patient consecutively presenting with this history, Tamsulosin or Alfuzosin, was enrolled. And we enrolled control patients. And each day a patient was enrolled, the surgeon would pick another patient who had never been on an alpha blocker, about the same age, put them in the study, same technique. And we were very concerned about masking the signs of IFIS. So we said, let's not have any alpha agonists, no epinephrine, and let's not even put it in the bottle. But certainly you can use pupil expansion rings, whatever you need to do to ensure a safe outcome. And then surgeons use their standard phaco technique. Well, every case was videoed. And these digital video files were sent to John Campbell and myself in the U.S., and we were masked. We had no idea whether the patient was taking either of the alpha blockers or was a control. So this is really the first masked prospective trial that has ever been done on that. And we gave scores to each case for IFIS, and if we didn't agree, we looked at the cases together and made a consensus. 0 meant no IFIS. Grade 1 meant some billowing, but really not a problem. And grade 2, moderate, meant there was billowing plus either iris prolapse or constricting of the pupil. Grade 3 was the classic triad that we reported with prolapse and meiosis. The most severe, the most likely to cause complications. So in all, we had 113 study eyes. You can see that Tamsulosin was still more common, but we had sufficient numbers. And then remember, there was a control eye by the same surgeon done every day. And this just shows the age, as was intended, was about the same. There were no surgical complications. There were no post-op complications. So given that there was no epinephrine in the bottle, the surgeons were not masked. And they were able to use iris retractors, and they were excellent surgeons to get those results. When we looked at the results, we find that IFIS is much more likely with tamsulosin compared to control. Well, that's not surprising whatsoever. But when you compare tamsulosin and alfuzosin here, look at grade 3, 34% versus 16%, statistically significant. So there was the answer. The most severe IFIS was more likely with tamsulosin than alfuzosin. If you compare people with large pupils versus people with small pupils, you see the difference in grade 3 IFIS, 80% versus 21%, a fourfold odds ratio increase. So we knew that grade 3 was statistically significantly higher with tamsulosin and alfuzosin over control, and tamsulosin greater than alfuzosin. Now, what struck us was that in the control group, 4% had severe IFIS with no history of alpha blocker. What's going on there? Well, the one thing that was different from any other trial that had been published is we omitted epinephrine from the bottle. And that was then the theory for why we were seeing that. And to test that, I did a separate sub-study, 127 consecutive cases with no IFIS risk factors, but taking the epi out of the bottle. I was not masked, but look how similar the results are. 8 to 9% had grade 2, 4 to 5% had grade 3, and 12 to 14, 2 or 3. So basically, it's the first time, I think, we have evidence that putting epi in the bottle actually does something. And it prevents us from seeing IFIS in our routine cases. So that was one conclusion. Tamsulosin is more likely a problem. Use epi in the irrigation bottle. Expect severe IFIS if you have a small pupil. Suvin brought this to my attention, the Indian study, largest to date, prospective. And it looks as though, again, the IFIS incidence is quite high, and a similar discrepancy, much more likely with tamsulosin than alfuzosin. So the message should be, if you're a patient and you have BPH, take alfuzosin, you'll have cardiovascular safety, less chance of severe IFIS. Now, in the United States and worldwide, there's been a shortage because there's no longer bisulfite-free epi. Epinephrine, you can have it preserved with chlorbutanol. You'd never use that in the eye. We're going to use single dose, unpreserved, and in India it's called Epinephrine. But what about bisulfite? It's an antioxidant, and Hank Edelhauser showed that in rabbit corneas it caused endothelial toxicity. So, of course, we recommended always bisulfite-free epi until it became unavailable. But what we've now basically advocated is if you're going to dilute it, and you have to dilute it anyway because the pH is so low, this is the recommended dilution. You add 0.8 of BSS to 0.2 of epi for your 1 ml, you're going to be fine. And that diluted bisulfite is not an issue. Phenylephrine, if you can get it, and in the United States, as in India, we don't have it, so we have to have it compounded, also works very well as a direct injection. Just the facts here. Look out for these generics. In India, Veltram and Uramax are the generics. And then I think I just want to go to the last thing, which is a survey that we did at UCSF this year to see how prescribing doctors, how aware they were of this with all the efforts we had made at education. So 90% have prescribed tamsulosin in the past year, fewer than 5 for alfuzosin. For BPH, what do you most commonly use? 44 said tamsulosin. Less than 1% are using alfuzosin, which is what I think we would recommend. And if the patient has BPH and a cataract, 20% said they're going to prescribe tamsulosin, an alpha-1 selective blocker. 43% said no preference. Are you aware that IFIS, that BPH meds can lead to complications? 2 out of 3 are not aware. And the 1 out of 3 that's aware, half of them say, I don't do anything differently, even though I know the patient has a cataract. When you start people on an alpha blocker, do you ask them if they have symptoms of cataracts? 90% said no. And if they're taking an alpha blocker, do you tell the patient, please warn your cataract surgeon that you're taking this? 70% do not. So that just points out the huge gap that we have in terms of educating prescribing doctors. And I think now there is actually a way to reduce severe IFIS, and that's to use the non-selective, non-Tamsulosin alpha blockers. Hopefully we can get the message out to our colleagues. Thank you very much.